So, Prof. Raymond Nienchenko, I'm sorry if I misspell your name.
Yeah,
Now, he's the
yeah,
associate
the
professor
pronunciation
in,
is correct. Thank you.
okay. He's the associate professor in Institute of Health Policy and Management in College of Public Health, National Taiwan University. So, his major is in including e-health policies, economic evaluation of software as a medical devices, and also to health insurance. That's why we invite Prof. Raymond today to share. And also his field of studies, healthcare and administration, is should be related with our topic today and also our student, especially our student is the third year students from the Faculty of Public Health, and they are also the specific majoring is about the healthcare administration and policy. So I hope we can discuss a lot more in the Q&A session later. And well, maybe we couldn't read all of the CV from Prof. Raymond, but he also has a lot of publication. Maybe if the students want to read more, you can also find his publication in the internet. Okay, maybe without further ado, today we will learn about the national health insurance from around the world, especially best practices from NHI in Taiwan, because we know that Taiwan is one of the country that have a good national health insurance. So we want to learn more about it. So we hope Prof. Raymond can share a lot about it, and also maybe we can compare a little bit. So I hope the other I already sent a few articles to the students to read before this session. So yeah, I hope it would be more interactive later in the discussion session. Okay, so I think, are you ready? Are you okay with the devices and connection there, Prof. Raymond?
Yeah.
Okay.
So is that
Yeah.
okay for me to start the talk today?
Yes, yes, time is yours.
Okay, let me share with my screen first. Okay. Good afternoon, everyone, and thank you for inviting me to give this talk to all the students and the audience online. I'm Raymond Guo. I'm an associate professor of the Institute of Health Policy and Management, College of Public Health at National Taiwan University. Um, yeah, something happened with my pointer. Sorry. Okay. So I'm also co-appointed at the Global Health Programs. The NTU College of Public Health is the first institution in Asia accredited by the United States Council on Education of Public Health. That's people call it CEPH, CEPH. And our students of the global health programs come from many countries, and the majority of them are from the United States. So for all the students who you are also interested in pursuing advanced degrees, you are welcome to apply to our global health programs. In today's talk, I will begin with the functions of a health system. Then I will introduce the basic characteristics of Taiwan's national health insurance. I will talk more about the global budget payment system because this specific payment design plays an important role in healthcare delivery in Taiwan. But it raises arguments and debates, especially from healthcare providers here. So let's start with the health system. By the way, you are free to interrupt me if you have any question, especially about if you cannot hear me clearly because I lost your connection sometimes at the beginning of this talk. So from WHO's definition, a health system is aiming to improve the population's health through the contribution of government or private organizations. So the effort in achieving this goal also require the collection of resources. So these are the building blocks of a health system. So service delivery here is one of them and is supported by human and financing resources. So people expect to receive healthcare that is coordinated, patient-centeredness, and with high quality and unfragmented. I think it can be applied to not only patients in Taiwan, but also patients in Indonesia and many other countries. So, but the question is how this brings up very huge challenges to all the healthcare system in many different countries. So it is not easy to answer this question, but how we pay the providers for their services should be a critical factor. So before I go into the details about the national health insurance here, I would like to give you an overview of what Taiwan's healthcare system look like. The total population of Taiwan is about 23 million, and it's about one-tenth, only one-tenth compared to Indonesia. And the GDP per capita is around 40,000 US dollars. But the national health expenditure here is only about 6.5% of GDP, so which is quite low compared to other OECD countries, especially those are with very good reputations in terms of healthcare. So also, Taiwan is a fast aging country. So about 16% of people are above 65 years old. So it raises the question that whether the national health insurance system can be sustainable if we only spend that low percentage of GDP in healthcare. And this slide shows that Taiwan's national health insurance is a single payer system, and it is compulsory. So, which means all all people who are eligible to enroll in the health insurance system, they should be enrolled. And it's run by the National Health Insurance Administration. So it's a single payer system and it's run by the government. So of course, it's a social health insurance program, which means it is not for profit. And unlike those private health insurance programs, which the premium is mainly based on the risk of healthcare utilization, the premium here under the national health insurance uh, is based on the affordability of enrollees, or say the income level of them. So that means uh, people, for those people with higher income, they will have to pay more premium to the national health insurance. And almost all of the population are enrolled. So it's 90, more than 99%. It's merely 100%. And also including foreign workers and students. So it is weird, but and it's funny because sometimes our local people say that our national health insurance is not only a national insurance, but it's a health insurance for the whole world because all the students and workers from other countries they can enroll in this system. Yeah. And also, more than 90% of the healthcare providers are contract with the National Health Insurance System. The total annual budget of this system is about 27 billion US dollars. And within Taiwan's healthcare system, actually, there's no gatekeeper in national health insurance. So basically, patient can receive care from any hospitals or any clinics contract with the NHI. So if you are interested in that, you can also you can Google YouTube videos. There are some video clips showing that foreigners for example, from the United States or from United Kingdoms or from other country, when they visit Taiwan, they went to receive care from our healthcare providers here, and they were so surprising about they can just make appointment maybe 5 or 10 minutes before they go to the healthcare providers the office. Okay. And also, large hospitals provide about 20% of the total doctor visits and 81% of the total inpatient care. Uh, so that means only 19% of hospital admission is provided by small community hospitals. So the provision of inpatient care here in Taiwan heavily rely on those large hospitals. And the average number of doctor consultation in Taiwan is about 14 per year, or 14 to 15 per year. And uh, uh, I'm sorry, I don't know the number in Indonesia, but if we look at the same indicator in Japan, it's about 12, and in Germany, it's about 10. But I want to mention that it should be very cautious when we compare the utilization of doctor consultations between countries, uh, because the number would be affected by the characteristics, social values, by law and regulations, and even some historical reasons. For example, because our system also pay for dental services and traditional Chinese medicine. So it's in total is around 14 to 15. And almost all activities happen in outpatient settings should be ordered or under supervision by a doctor in Taiwan. So for example, receiving a flu shot or a nutrition education in Taiwan, it will go through a doctor visit first. So of course, it will raise the number of doctor consultations per patient per year. And the National Health Insurance started in 1995, so we celebrate our 30 years anniversary last year. But it is not a whole new system, but actually it combined the healthcare benefit packages from the labor insurance, the government employees' health insurance, and the farmers' insurance, and some other parts of health, public-funded health insurance. But as you can see here, before the implementation of national health insurance, actually, less than half of the population had public health insurance. So that means more than half of people, they don't have any kind of public funded health care before the implementation of national health insurance. And the insured, which means the general population, contributes about 34% of the total premium to the national health insurance. And the private employers contribute another 30%. And by the regulation of the national health insurance law, the government, they should contribute at least 36%. And basically, the national health insurance here cover almost all of those common types of healthcare services. So just like what I said, even the traditional Chinese medicine is covered by the system. But some new and expensive drugs or medical equipments, for example, the very new immune therapy for cancer patients, are not covered. So recently, we have a new, we call the cancer drug funding, and also new drug funding to deal with that some very expensive and new drugs cannot be covered by the national health insurance immediately. So we have different mechanism to deal with the problem. And so so just like what I mentioned around 100% of population is enrolled, and most healthcare providers are contract with NHI. So it is not surprising that people in Taiwan have a very high satisfaction with the national health insurance. And also, according to, as you can see here, it's a report from HSBC. Taiwan's healthcare is of very high quality with high affordability compared to many other countries. So you might think that it's too good to be true, right? Especially here in Taiwan, some healthcare professionals, they think we can be ranked, have that unique reputations because uh, uh, they are sacrificing in terms of low salary. But actually, it's not true because they compare their salary with their counterparts in the United States. Okay, so doctors here in Taiwan, actually they are a high income occupation. Yeah, but they think compared to their counterparts in United States or in Australia, they think their income, their salary should be higher. Okay, so they're sacrificing to the system. And also, this is a very recent published reference saying that Taiwan's healthcare has been ranked the top one among 94 countries in the world. So in terms of their healthcare index and life expectancy. So as you can see here, Taiwan's national health insurance and combined with the healthcare system has very good reputations. And the people here in Taiwan, they are quite satisfied with the system. Okay, and so let's move to the payment system. Remember the golden rule says whoever has the gold makes the rule. So financial incentive is a major motivation for human behaviors. And it also plays a critical role in shaping the way how healthcare is delivered. So the first payment system here in Taiwan under the national health insurance is fee for service. And perhaps it is the most commonly used payment system in the world. And many countries, including Taiwan, use fee for service to pay for healthcare in earlier years. And even now, the majority of healthcare services, including outpatient and inpatient care, are reimbursed through fee for service here in Taiwan. So the amount of payment is determined by the type and value of services consumed. And in literature, this payment system is also called payment by item of service. So this payment system is quite intuitive, just like eating in a restaurant. And so you pay for what you order, right? So if you eat more, you pay more. And like many other countries in the world, Taiwan's national health insurance experienced a fast increase in medical expenditure since it was launched in 1995. And as you can see here in 1999, it was the first time that medical expenditure exceeded the collected premiums. So the total medical expenditure in 1995 was 157 billion new Taiwan dollars, and it rose to 286 billions in 1999. So which is about an 80% increase compared to the beginning of the NHI system. But the premium only increased about 36% within the same period. Okay, so why has the healthcare expenditure risen so fast? The increase of accessibility to healthcare after the implementation of NHI is one reason. But the rise in expenditure was also driven by the fee-for-service payment. So it's a feature of this payment system because it provides financial incentive for providers to order or to provide more service to the patients. And the rise in healthcare expenditure urged the government to adopt new strategies to contain the cost. And one of the strategies is the global budget payment system. And I would say that a global budget might be the most important payment reform since the launch of NHI here. And it brought a huge impact on healthcare delivery in Taiwan. So I would say it's the most important and the most arguable policy about national health insurance here. So let's move to global budget. So what's global budget? A global budget payment system is prospective, so which means the amount of payment is predetermined before the service is delivered. So under this system, payers and providers have to negotiate the budget for a fixed range of healthcare services for the upcoming year. So this approach is called collective bargaining. So it is not through voting, but all representatives of stakeholders should discuss and come up with an agreement on the growth rate of next year's budget. And unexpected healthcare needs will be covered by the insurance, but are not included in the budget. So such as the COVID-19 pandemic or healthcare resulting from catastrophic disasters will not be covered by the budget. But the healthcare for that disasters will be covered by the insurance. So that means the government should find another funding to support for this excess healthcare utilization. So this is an example. In 2015, there was a massive explosion in a water park in northern Taiwan. So that was caused by the spray of, as you can see on the slide, of those colorful powders in a musical festival. So it turned out that a total of 500 burn patients, most of them are young people, were sent to emergency department of large hospitals. So you can imagine treating those burn patients very expensive. So not to mention the cost of following rehabilitation. So just in the first year after this disaster, healthcare cost 765 million new Taiwan dollars. So the government and the NHI allocate an extra budget to cover the cost of treating those patients. So there are three main reasons to implement the global budget in Taiwan. First, this system is designed to balance the affordability and the demand for healthcare. Because in the past, there were two independent committees in charge of budget allocation and negotiation of the volume of service provided in NHI. So it happened that one committee decided to purchase more healthcare services, but unfortunately, the financial revenue to be collected was not enough to cover the projection of utilization. So which was mostly determined by premium rate passed by another committee. Okay, so that causes problems. And the second purpose is to avoid political conflict against the change of premium rate. In the past, although the premium rate was discussed and proposed by an independent committee, but our Congress here has the right to make the final decision. Okay, so it happened several times that the National Health Insurance Administration, which is the agency that runs the NHI, should raise the premium rate to account for rising healthcare costs. But Congress refused to accept this suggestion, and therefore it was quite crucial to develop a platform that stakeholders, including consumers, employers, healthcare providers, and the governments, can negotiate for the budget as well as the healthcare services to be covered by the insurance. And the third purpose of implementing the global budget is to improve clinical autonomy. So theoretically, allocating a fixed budget can encourage providers not to overuse unnecessary services. Because at the macro level, no matter how many services are provided, the providers can receive the same total payment under this global budget design. But as you can see, I put a question mark here because honestly, this goal is never achieved. So if at the micro level, healthcare providers are paid through fee-for-service or other type of retrospective payment systems, there are always incentives for them to increase the service volume for better financial return. And the National Health of the global budget, the dental care in 1998, followed by traditional medicine in 2000, then the primary care and hospital sector in 2001 and 2002. So it could be harder if we ask all healthcare providers to be covered by the global budget from the very beginning and allocate a huge budget for the whole market. So it looks like this sectorized strategy is a success. However, I would say that it also causes the problem to integrate different healthcare providers to deliver unfragmented care. So it's our big challenge here to provide patients with a seamless and unfragmented care because of this feature of global budget system. And this is a share of the budget among the sectors. The hospital sector is allocated with the biggest part of the annual budget, which is about 65% of the total budget, followed by primary care and dental care. And the growth rate of the budget is affected by several factors. So the growth of population, the change in the structure of population. So, for example, the aging and the cost index of medical services belong to the non-negotiable factors. And so this part means that the change of these factors will contribute directly to the growth rate automatically. And the costs related to the changes in payments or the cost of programs to improve the quality of care are examples that should be included in the negotiation. Also, other specific programs, such as covering the cost for new drugs to treat hepatitis C, will be allocated a specific budget. So based on those non-negotiable factors, a projection for the range of growth rate will be determined by the government before the negotiation. And the final growth rate should be within the range. So as you can see on this slide, from 2013 to 2018, the growth rate are between 3.3% to 5.6%. Then the budget of each sector is reallocated to 6 regions based on the risk-adjusted population and historical share of the budget of each region. Okay, so from sector to regional level budget. So providers then are paid through the micro level payment system, such as fee-for-service, diagnosis-related groups, DRG, and pay-for-performance. And this figure shows how hospitals and clinics are paid under the global budget. The medication are paid at a fixed point value that a point is equal to $1. And preventive services and healthcare in rural or remote areas are also paid with a fixed value. The rest services are paid through fee-for-service or DRGs are subjected to the floating values. So which means more services are provided, the lower point value is assigned. Okay. And this equation explains how to calculate the monetary value of a point. So the point value under global budget here equals the total allocated budget minus fixed value point. Then the amount is divided by the total floating point claimed by the provider in the specific region. And this point value is recalculated quarterly. So before implementing the global budget, the point value was fixed at 1. So which means social health insurance present the monetary value of the payments and amount of floating point times the floating value. So this equation is used for adjustment purposes because provider are paid monthly based on the point value of the previous quarter. And ideally, the global budget can encourage providers to deliver healthcare more efficiently and reduce unnecessary utilization. This example show how this might work. So let's say $95 billion is allocated for hospitals in a specific region. So if at the end of the quarter, all hospitals of that region together claim 100 billion points, 100 billion points. Okay, so it turns out that the point value is 0.95. So under this scenario, a hospital claimed 40 million points and will be paid $38 million. So that's 40 times 0.95. So it's equal to $38 million. So in this scenario 2, hospital claim fewer points than in scenario 1. So the point value is higher, right? The point value is 1.06. So under this situation, this hospital, A hospital, can receive the same payment even if it provided fewer services. However, in the real world, Taiwan's global budget tells a different story in terms of providers' behavior against this payment system. So as you can see here, data show both the number of outpatient visits and the point claim kept increasing after the implementation of the global budget. And the growth of total points was even higher than the number of visits. The number of cases increased 20% in 18 years, but the number of claim points increased 140% with the same time. So it's more than double in 2015 compared to the number of 1998. And the data of hospital admissions also tell similar results. So look at the slope of these two curves. Okay, the growth of total point was higher than the number of admissions. And the number of cases increased 40% in 18 years, but the number of claim points increased 114% percent within the same time. The rise of healthcare utilization and costs result in that the monetary value of floating points were below 1 for most of the time among all these sectors. So as you can see the graph here. So most of the time, the floating point value were under 1. So especially the dialysis sector and hospital sector. So what are the intended and unintended consequences of the global budget in Taiwan? The payment system is successful in terms of cost containment, right? The growth rate were within a reasonable range of considering the affordability and need for healthcare. However, most of the time, the monetary point value were below 1. So this means comparing to the days before the global budget was enforced, providers receive fewer payments for the same services. And this is because for the majority of the services, providers are paid based on fee-for-service, except limited inpatient cases are reimbursed based on DRG and some pay-for-performance programs. We will talk about that later. And under this circumstance, it is a zero-sum competition because the budget is fixed at the macro level already. So based on the game theory, healthcare providers can still benefit from increasing their service volume if their cost, their true cost, is still below the payment. So those low-cost providers, usually private hospitals, are more competitive in such a situation. So medical professionals argue about the low point values, especially doctors. They argue that it is unfair to force them to accept a discounted payment. And providers are even asked to return the payment to the national health insurance when the point value decrease, while they were already prepaid by the previous quarter's point value, which was higher than the exact point value after recalculation. So this also affect how medical students choose their medical specialties. So medical students also want to apply for specialties they are with better revenue under the global budget. For example, those specialties which can prescribe expensive medicines are more attractive, or those specialties provide more services that are not covered by the insurance and are paid out of pocket. Okay. So the global budget also caused barriers when referring patients from one sector to another. For example, the government has a policy that encourages large hospitals to refer their patients to local clinics for follow-up care. Because providing primary care at large hospitals is much expensive and is inefficient. But the societies of local clinics are more concerned about the negative impact on their point value because the policy does not reallocate budget from the hospital sector to the primary care sector for these referrals. And healthcare providers also tend to promote services that are paid out of pocket, such as robotic surgery, high-tech health check, and other new technologies. Even services unrelated to care become important sources of revenue. For example, the parking lot and food court of a hospital become important in Taiwan. So before we move to the next topic, I would like to mention that Taiwan is not the only country in the world that adopt a global budget payment system. So this table is from a report published by the Commonwealth Fund in the States. As you can see here, Australia, Canada, Denmark, and Germany have implemented the global budget. However, unlike Taiwan, they are using the global budget in the hospital sector only. Okay, so and next, let's talk about the pay-for-performance system. So just like what I said previously, if the National Health Service pay providers uh, based on retrospective payments, and that will cause that the providers' own costs are fully reimbursed after the service are provided. Okay, so providers may have incentive to increase their cost and hence to increase their income. And this kind of retrospective payments is also argue about that the payment is not linked to outcome. So that means uh, if you have worse quality of care, actually you can get better reimbursement because uh, the patient may stay longer in your hospital and receive more healthcare interventions compared to those providers with better quality. And so the provider's payment rate or budget are determined before the service provided. So there's no link with individual's cost of the provider in prospective payments. So this system have more incentive to stimulate efficiency than a retrospective payment system. For example, the hospital DRG payment. I don't know whether this same system is also uh, applied to the Indonesian hospitals. But also, the prospective payment system like DRG is not linked to outcome. And as you can see here, if you have the chance to visit Taiwan, especially Taipei, many of the tourists or our visitors, they will go to the famous restaurant called Din Tai Fung to have a taste of the soup dumplings. Is quite famous here and also in many other countries. So they have branches in many other countries in the world. But their soup dumplings are expensive. It's more than two times or even three times compared to those street vendors. So you can find those cheaper soup dumplings in from street vendors or in other cheaper restaurants. So think about that. If our government say that we set um, a fixed price for soup dumplings, and the price is much lower than the price that the restaurant Din Tai Fung to sell their soup dumplings. So if that's the case, I bet that Din Tai Fung will know they will not provide soup dumpling in the future, right? Because uh, they are not rewarded with their better quality in terms of their food. But actually, in healthcare, we are doing that things, right? We set a fixed payment for healthcare providers, no matter the quality of care, what's their quality of care. So some of you might read or heard about this famous IOM report, Crossing the Quality Chasm. And
Yes.
in, sorry, is anyone want to interrupt me? Because I hear some voice. Okay. Because in this report, uh, the IOM figure out that there are 6 M's of healthcare: safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. However, at that time, the report published, there's no payment system support. There's no payment system support the pursuit of these M's. So what is pay for performance? Actually, is this kind of payment system is one to solve the challenges that we mentioned uh, earlier. So the payment system is link uh, financial incentives with quality of healthcare. So it reimburses providers based on the patient's outcomes. And this kind of payments encourages providing patient-centered and continuity of care to the patients. So the idea is simple. And this is what we do here in Taiwan. Actually, we have many different pay-for-performance. Usually people call it P4P in literature. So we have many different P4P programs here. Some are disease-oriented, so including diabetes, breast cancer, cervical cancer. And some are service-oriented. So for example, patient-centered clinical care, emergency department P4P program, etc. So the P4P programs here, healthcare providers, they are voluntary to participate in those programs, but providers must meet the following criteria. First, they have to pass some qualification or certifications, and the care provided to the patient should follow treatment guidelines. And also, the P4P programs here establish case management systems. So the healthcare providers and also the NHIA, the government agencies, use these systems to monitor quality. So for those healthcare providers participate in these programs, they must submit data to the NHIA except claims data, which means they also uh, except claims data, they also have to submit some self-reported performance data on the outcome dimension and process dimension of quality of care. Okay. And before the last part of this talk, I would like to share with you some effort that the National Health Insurance made about adopting information and communication technology. Uh, Actually, there are two major achievements. One is called My Health Bank here, and which is provide information back to the people, to the enrollees. And the second one is called the NHI MediCloud, which is exchanging the health record among healthcare providers. So people in Taiwan can access to My Health Bank using a web browser or an app, so on their mobile equipment. So people can check their personal health records through My Health Bank. And the information covers the healthcare records uh, of ambulatory care, inpatient care, dental services, and all record of medication use. And these are the types of information shared on the MediCloud. So MediCloud is for healthcare providers. And the MediCloud includes a very broad spectrum of health records. So as you can see here, it covers surgical record, all examinations, dental care examination results, and discharge summary. So that means if a patient discharged from a hospital and receive follow-up care from a local clinic, the doctor at local clinic can check those information on the MediCloud to check the specific patient or what type of service the specific patient received from the hospital. Oh, sorry, I forgot to mention one thing. Uh, Not only for people here in Taiwan, they can not only access to their personal healthcare data, uh, they can also share their healthcare information with their spouse, their relatives. Okay, so for example, if you have kids, you can use this My Health Bank to check the kids' health record. Or if you have elderly family members, even you don't live with them, you can help them to check with their medication prescriptions, and you can check with their examination to see whether their chronic disease are under well control. Okay. So it's a unique feature of our My Health Bank here in Taiwan. And the MediCloud provides the results of medical imaging since 2017. And right now, the National Health Insurance require doctors to check the MediCloud before they order a CT scan or MRI. So unnecessary retake of CT scan or MRI are not allowed within 90 days. And that saves a lot of money. This figure shows that the MediCloud prevents duplicate medications. So it's not only save money, but also improve patient safety in medication. The health information technology is also adopted for telehealth and home health care. Okay, so this kind of health information technology helps our healthcare providers here to provide better service for our people, especially those live in rural areas. So if you are interested in what happened since the implementation of national health insurance here in Taiwan, there's a new book published just a few years. And it has an online open access version. So this book provides some details about the national health insurance in Taiwan, not only the digital advance, but the features and performance of the system. So you can download it if you are interested to know more about the national health insurance in Taiwan. Okay. So that's the contents I prepared for today's talk. So that means I leave quite much time for the Q&A or discussions. So I'm happy to take your questions.
Okay, thank you very much, Prof. Raymond, for sharing. I think we have a lot of insight and new things that we learned from your presentation. So I welcome for all the participants. If you want to ask, you can raise your hand, or maybe you can chat in the Zoom. And also, if you are afraid, you can also chat on Bahasa Indonesia, and I will translate it to Professor Raymond. Bu Kris, silahkan.
Biar mahasiswa dulu. Dan first.
Okay.
Dia, yes.
I'm sorry, I cannot hear you clearly.
Yes, maybe my student first to ask a question, Prof. Raymond.
Yeah, please.
Okay, sure. So for the students, do you have any questions? Silakan kalau ada teman-teman mahasiswa yang mau tanya ya. Oke, Kalisa.
Baik, Ibu, terima kasih atas kesempatannya. Mungkin saya akan bertanya dalam bahasa Indonesia, dan pertanyaan saya mungkin agak panjang. Apakah vokal saja, verbal saja, atau di chat saja ya, Bu?
Ditulis aja kalau bahasa Indonesia, nanti saya translate. So if you want to ask but in Indonesia, I will translate it for you later, Professor Raymond.
Oh, okay. Thank you. That's quite a big help.
Yeah, sure. Okay, maybe she will write it in the chat. Zoom, while waiting for Kalisa, any other students want to ask? No, maybe waiting from other students. Okay, so we have Kansa here. She asked about, well, wait, let me read it. Oh, the healthcare system in Taiwan didn't apply the gatekeeper mechanism. So in Indonesia, we have this gatekeeper mechanism. So all of the community, the NHI participants, have to go to the primary healthcare first. Then they can, if it's needed, they can refer to the hospital. So, but in Taiwan, it seems that all of the patient can access the healthcare in clinic or the hospital without referral system. So, in that context, how the government makes sure that this access, that it's easy for them, didn't make it become overutilization of the healthcare system, and also because of the high visit of the outpatient services in hospital. So how do you make sure the quality and the time services, so it's correct and fast in the healthcare and in the hospital without burden the resources in the hospital? And what about the design or the
Yeah, thank you.
payment mechanism about that?
Yeah,
It's quite
thank you.
long.
That's a very good question. And yeah, thanks to Google Translation, actually, I can translate the text message into English or Mandarin. Yeah, that's a good question because yeah, I just like what I said. Actually, we don't have the gatekeeper mechanism like what happened in, for example, United Kingdom. So for people living in United Kingdom, you have to register to a primary care provider there. So whenever you have a healthcare need, you have to go to your family doctor first before you can be referred to large hospitals or those specialty care. And in Taiwan, we actually we don't have those kind of system, but like many other health insurance system in the world, we have co-payments. Okay, so co-payments is a mechanism that to prevent, we call it moral hazard. Moral hazard means that the lower cost of care, the more utilization might happen. So we have a co-payment, but of course the co-payment here in Taiwan is quite low compared to, for example, the co-payment in Japan or in the States. And for some special case in the States, the co-payment can be more than 40% or even more than half of the total cost of a treatment or a doctor visit. But in Taiwan, it's pretty low. But we still have that kind of mechanism, the co-payment to prevent moral hazard. And also, for those heavily users, which means if a patient go to see a doctor more than 100 times per year, we have a special program to help them to use their healthcare utilization more efficiently. So for those high users, the NHIA will assign them to a large hospital, usually a medical center, okay, and ask the patient to receive care from that specific large hospital. So that means for those high users in Taiwan, they no longer have the privilege to receive care from any providers. They can receive care from that specific large hospital. Okay, so we have some different mechanisms to overcome the potential moral hazard. And the second part of the question, yeah, it is also very important. How can we balance the quality of care at a time when the service volume is that high? So, well, so that's health information technologies play a very important role here in Taiwan. So every hospital, every clinic, they have very efficient use case of health information technology. For example, the health information system, HIS, health information system in hospitals, they help the doctors to provide a consultation to patients in a very efficient way. So because most of the patients will make a reservation before they go to see a doctor, right? So once the health information system knows that there is a patient will go to see a doctor tomorrow, so during the midnight, the system will pull all the information of that patients together, especially within, let's say, 1 week or 2 weeks, or to pull the medical records of the patient's last visits, or even the prescriptions. So once the patients sit behind the doctor already have all the information he or she need for treating their patients. Okay, and remember that we also have MediCloud. So that means the doctor can also access to the information happen outside his or her facilities. So that helps quite a lot to improve the efficiency and also the quality of care. Okay, also, many large healthcare providers, especially medical centers, those large hospitals in Taiwan, they have some quality monitoring system. For example, if a patient see a doctor and some specific indicator or health indicator of patients is exceeded acceptable range, then it will trigger an alarm to the doctor. So to remind doctor to do something for the patients. Okay, and that's at the provider side. But for the NHIA side, for the National Health Insurance Administration, they also have, you can imagine that they have more than 2,000 quality indicators regularly monitoring the quality of care across the healthcare providers. And not only the staff of National Health Insurance can check the quality information, but also these information are feedback to the providers. So each providers here in Taiwan, they can access to those quality metrics. So they can see their own performance and they can compare their performance with their peers. So clinic can compare with other clinics. Medical centers can compare their result with other medical centers. And also, we have a system, it's not unique in Taiwan because some countries also have that. We call it report card, hospital report card, or healthcare quality report card. So which means our people can go to that specific website. It's developed and maintained by NHIA. So it provides certain quality indicators on that website. So before the patient go to see a doctor in a hospital, they can check the quality of care of that specific hospital. For example, what's the proportion of diabetic patients receive HbA1c test within a year? Okay, so it's a process dimension quality indicators to show whether the doctor or the providers, they order the HbA1c test for the patients to monitor their glucose level. So the patient also can access to those quality information, but not all these 2,000, but some selected indicators will be provided through the report card system. Yeah.
Okay, thank you. I think, well, it's answered a lot about the question from Kansa earlier, but well, we also have got a lot of new information from your explanation before, but let's move on to the next question. From Kalisa, she asked about the pay for performance mechanism that you explained earlier, and how much the percentage between the global budget and the P4P for the healthcare. Is there any percentage or any specific mechanism to determine which one, how much is the global budget and how much is the P4P for the each healthcare, and also how to control the quality and while make the cost efficient, because that you explained earlier, we saw a lot of healthcare facilities, especially in the private sector, like the clinics and stuff, and how they maintain so they can get the profit from their services. And she also actually have two questions, but maybe this first one, because you can answer the first question first and I can explain the next question.
Okay, so the first one is about P4P and the second one is about
At first selection.
reverse selection or
At first
variable
selections.
selection, right?
Yes,
Okay,
yes.
so actually for the first question, I don't have the real number or the real percentage of budget allocated to P4P program. But there might be a misunderstanding if the translation is right. Actually, the P4P program, there's no actual budget for the P4P, but the P4P, the reimbursement from P4P, the global budget. Okay, so there's no fixed amount of budget for P4P for each people. No. There's no fixed budget for it. We only have fixed budget for different sectors, but we don't know. Actually, there's no fixed budget for single services or single disease. Although doctors, they expect in the future they can have their fixed budget. So, yeah, surgeons want a fixed budget for surgeons. Pediatrics expect a fixed budget for pediatrics, but that's not the case here in Taiwan. Yeah.
Okay, but for the second question about the reverse selection, especially in
And
informal sector.
yeah, sorry. Before I answer the second question, I would like to say more about the how the system monitor or maintain quality of care
Okay.
here in Taiwan, because it seems that students are more interested in about the quality of care
Yes.
here in Taiwan. Except what I said about to collect and monitor quality of care among health care providers. We also have hospital accreditation here in Taiwan.
Yeah, like
Okay,
I mentioned.
and our hospital accreditation system can be traced back to even more than 40 years. We are the first country in Asia has hospital accreditation. So during the accreditation activity, each hospitals need to prove they provide good quality of care to their patients. Okay, so and also within the requirement of the accreditation, it requires all hospitals to have or to join at least one kind of quality monitoring system, except what I said, the 2000 indicators monitored by the NHIA. There are also some different quality monitoring system. So they will collect those healthcare quality informations and to share with the peers. Okay, so maintain the quality of care is a consensus here among healthcare providers. Yeah.
Yeah, okay. So is it also, well, continuing from your explanation, is it also applicable for the primary healthcare or clinics for the monitoring the quality system, or is it just for the hospital?
For
No
the
services.
quality indicator monitored by the NHIA, it covers primary care. But for those volunteer joined quality monitoring systems, it only happened to hospitals, but it covers from large hospital to community hospitals. So they have different systems. For those large hospitals, they tend to join a more sophisticated system, which means they collect more quality indicators. And for those community hospitals, which are smaller, much smaller, they tend to join with a system that collect some less quality indicators. Yeah, because collect quality information, it costs quite a lot.
Yes.
You have to hire staff to help the doctors or nurses to collect those quality information. Yeah.
Yeah, okay. Okay, let's move on to the second question about the reverse selection, especially in the informal sector, how Taiwan solve this, because it happens a lot in Indonesia because we know we have low literacy in health financial and also especially about health insurance. So most of the people that already know that they have the health risk, so they tend to apply for the insurance. But if they don't have the health risk, they are like don't want to apply for the health insurance, or they don't pay for the premium. So is it also happens in Taiwan, or what? Maybe can you share something about it?
I would say those kind of patient selection, or people say patient dumping in the States. I would say the case here is pretty different than what you have as my imagination. Because here, every patient, they have if they go to see a doctor, no matter the health literacy of that patient is higher or lower, the payment for that patient is the same, actually the same among all the patients. So there's no incentive for a hospital or clinic to select patients with high socioeconomic status or with high education level. But to be honest, our hospitals or clinics, sometimes they will also select patients, but not based on their socioeconomic status, but based on the severity of disease. Remember I said we have some P4P program, right? The payment is linked to the quality of care. Okay, and for those patients with more severe disease status, they tend to have worse outcomes. So if they have more those kind of patients, their performance in the P4P program tend to be worse compared to their peers. So there are some papers demonstrate that for our local doctors here, they tend to pick up those less severe diabetes patients to be enrolled in diabetes P4P program. And so the NHIA also have a policy to deal with that. So the NHIA will give the providers the potential patient list to ask them to enroll the patient to the P4P program instead of to allow the provider to select the patient they want to be enrolled in the P4P program.
Okay.
Yeah.
Okay.
Yeah,
Well,
but of course, and there's also some cases that because we also have a DRG system. So if a hospital receive a patient who is more severe, they might lose money under the DRG payment. So for that case, they have the incentive to refer the patients or to avoid the patients. So they will. So if a patient go to an ER and the doctor sees that the patient is severe, they might tell the patient that you should receive care from
hospital.
NTU hospital because they are more capable to deal with the situation. Yeah, something like that.
So, but the adverse selection here is not about the hospital base, but about the NHI participation. So, well, policy-wise, the NHI participation in Indonesia also compulsory, but it's not all of the people are applying for the program. And also we have to pay the premium for several categories of the people in Indonesia. So that's why some people in Indonesia didn't want to apply for the program or pay for the monthly premium because they don't feel sick, because they feel they don't need the healthcare facilities. So they just don't want to pay for it. So it happens a lot in Indonesia because they don't understand that it's actually the insurance mechanism and stuff. So is it also happening in Taiwan, or is it just compulsory for other people so they don't have any choices to participate or not in the NHI insurance?
No, they don't have the right to opt out from the system.
Okay.
And that's the definition of what called compulsory social health insurance.
Yes.
If you allow people to opt out, then you cannot call your system compulsory. And that will bring you a very big challenge, because remember that those healthier, younger people, they tend not to be covered or to enroll in your health insurance system. So those enroll in the system, at least they know they have the need for receiving health care, right?
Yeah.
So they will have your premium very, very high if you cannot enroll with those younger or healthier people in the risk pool. Okay, so at the end, it will bring you a very large problem. Yeah. So you can imagine that after some years, people won't want to get enrolled by your health insurance system because all those in the system are sicker patients. Why should I pay for their health care?
Yes, and that's what happened.
Okay.
Okay, thank you. Before we go to Ms. Putri question, maybe we go to Dr. Chris Wardani first, because it's just related with previous question. She wants to explain a little bit about the NHI, and maybe we can discuss after that.
Yes, Prof. Raymond, thank you for your explanation about national insurance in Taiwan, because Taiwan is one of the countries that Indonesia learned to develop national health insurance, besides Germany, Thailand, and maybe South Korea. Yes, we implemented national health insurance in January 2014, almost 11 years ago. And the participant divided into two. Most of them are compulsory. First, for poor, subsidized by government, both central and local government, premium paid by government. And the second, for not poor, they pay from their pocket. Okay. We have very cheap premium. I don't know how much in Taiwan, because you have a great big GNP per capita. Of course, it's different with Indonesia. The participant should pay depend on the class of the hospital. First, second, and third. For third class, they pay maybe in US dollar only. Yes.
Sorry, are you saying that they pay different premium or
Yes,
different?
Yes, premium. The participant pay premium depend on the class of hospital inpatient.
Oh, okay.
Yes, first class they pay about 10 US
Is that
dollar.
the
10
premium or
US
the
dollar, yes.
co-payment? So
No,
that
No,
are different.
premium.
Premium.
We,
So
yes,
even they don't receive care, they pay that class
yes,
of money
yes,
to
every
the
month,
hospital
every
or to
month,
the
yes.
Okay.
First class,
So do you mean that Indonesian people, they can only receive care from a specific hospital? they register too? Because you say your premium is based on the
Yes,
class of
and
the hospital.
every hospital they have three type of inpatient. Inpatient, yes.
Uh-huh.
The premium, the rate of premium for the first class about $10. It's very cheap. 10 about similar
Y-
$10, and the
Yeah.
second about $5 per person per
Uh-huh.
month, and the third class only about $2.
Uh-huh.
And of course, we have a big deficit in every years because the low rate of premium paid by participant cross to the spread of benefit, many benefit from common disease until dialysis covered by National Health Insurance. That's
Mm-hmm.
our problem. We have a deficit in every years. Okay, and of course we have different total population. Indonesia have two 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 280 million population, and we have 3,000 and about 3,500 hospital, and we have about 10
Mm.
million puskesmas, community health care,
Yeah.
and health services divided into two. First are primary community health services belonging to government and private clinics, and the referral, the patient will go to outpatient specialist
Okay.
and hospital. Yes, and until now, the coverage is about 97 or 98% of population. And of course, it's very fast to reach almost universal coverage in 11
Mm-hmm.
years. Yes. And I have some question,
Yeah.
Prof. Raymond. You mentioned before that the system payment um, uh, from FIFA services to global budget, any deficit in
Yeah.
NHE financing, and then do you have a difficulty in developing referral system because it's very different with Indonesia. We have archipelago country, thousands island we have, and the difficulties is accessibility of the participant, especially in islands in remote area. Okay, do you have obstacles in conducting referral system? And what about the uh, consumer satisfaction, participation test satisfaction from NHI and from hospital services? I'm sorry, health services. What about participation satisfaction? Yes. Yes.
Okay. For the referral,
Mm,
uh, well, I will split the case for people live in urban areas and those
uh,
who live in remote area. Actually, because um, Taiwan is a small country, although the
mm,
population is equal to Australia, but actually it's a
mm,
small island country. So accessibility in terms of traffic time in Taiwan is
mm,
not a huge problem, except those people live in a mountain area or some remote areas.
mm,
So if a patient go to see a doctor at local clinic, and the doctor determined that the patient should be referred to large
mm,
hospitals, then the doctor will will write a referral form, either paper-based or electronic. So the doctor can refer the patients to a hospital close to the clinic. So through paper-based or through electronic system. So referral in urban areas, in most of the areas in Taiwan, is not a problem. And of course, for those people in remote areas, that could be a problem. So there are many different policies to deal with the problem. Some are under NHI, some are not under NHI. So for example, remember I said we have hospital accreditation, right? So there's one rule that says for hospitals, if they want to be accredited as a medical center, which is the highest level here in Taiwan, if you want to be accredited as a medical center, you have to assign and their medical doctors, nurses, pharmacists to a remote island to provide services there at a regular basis. Okay, so for those people living in remote island, actually they can see those doctors actually practice at Taipei City or those big cities in Taiwan because the doctors, pharmacists, and nurses are sent from medical center.
Yes, it's
okay.
I'm sorry. Do you have problem in deficit financing in NHE in Taiwan?
Yeah,
deficit and financing.
Yeah, yeah, that's why we actually we call right now our system, we call it the second generation of national health insurance since 2012 or 2013 because we passed a revised national health insurance law. After that, we actually just like what I said on the slide, we have a national health insurance committee. So the committee will, one of the committee's task is to discuss whether the premium rate should be adjusted. Should we set a higher premium rate or should we have a lower premium rate? So we have that platform to deal with the premium rate adjustment. So once there is a deficit happen in the previous year, and if the deficit is above the threshold, then it will trigger the discussion about the adjustment of payment rate.
Okay.
Okay, and because I'm not a guy in the financing part, I'm a guy in healthcare quality and payment. But for the financing part, actually they have, by the law, they have 2 months of safeguard or safety funding threshold. So which means the NHI should keep at least 2 months of the expenditure. So if the safety level is below 2 months, it will trigger the discussion to adjust the premium rate.
Okay.
Yeah.
Excuse me, another question. How much rate of premium compared to US dollar in Taiwan? Because I mentioned before, it's very low in Indonesia.
Okay, our premium rate is about 5% right now. 5%. So actually I checked
5% from what?
from monthly income.
Monthly income. Okay.
Yeah, from monthly income. So let me see it. Actually I check it.
Yes.
So for a person whose monthly income is 100 for those with $1,000, sorry, I have to do the calculation.
Wow, it's a huge.
No. Oh, sorry. For the lowest level is about monthly income around $1,000, and they have to pay for $40 monthly premium. But not all those $40 directly comes from enrollees, they only have to pay 30% of the $40. Their employer have to pay 60%, and the government has to pay another 10%.
Okay.
Okay.
Thank you. Thank you very much.
And that's the lowest level of the premium, the amount of premium, because we have a table. It lists all the different category of income and what's the premium. But right now the premium rate is 5% of monthly income. Yeah.
Do you have problem in catastrophic disease, Prof. Raymond? Catastrophic disease. Do you have problem in your country with catastrophic disease?
Yeah,
Like
that's a question.
non-communicable disease, degenerative disease like cancer, chronic renal failure.
Those are covered by the National Health Insurance.
Okay.
Those are covered. And right now, actually, we have a classification of those catastrophic diseases. And it's covered around 200 or maybe close to 300 diseases. So including any size of cancer.
Yes.
And end-stage renal failure, something like that. And for those people who are diagnosed with those catastrophic diseases, they don't have to pay copayment when they receive care to treat their diseases.
Okay.
Okay, so there's no copayment for those diseases, and the cost of those diseases are covered by NHI. Yeah.
Thank you very much, Professor Raymond.
You're welcome.
Thank you.
Yeah.
Okay, thank you for the long explanation. Maybe you want to get some drink first. It's all be okay because we still have
it's okay. It's okay. Yeah.
Because we still have a lot of questions here. Well, from Ms. Putri, she asked about the system allow relative free access to specialists without strict referrals. So from your perspective, is this a strength or potential risk? And how effective is the global budget approach in controlling healthcare costs while maintaining the service quality? Again, question about quality in healthcare.
Okay, so a lot of students concerns about quality of care, while we have very good access to care here in Taiwan. Yeah, yeah, that's a problem here. Because before the implementation of National Health Insurance, at that time, although not below 50% of the people, but around 40% of people, they have at least one kind of public funded health insurance. And at that time, there's no referral system. Actually, in Taiwan, there's a long debate whether we should enforce a more strict referral system here. So just like what happened in the United Kingdom. But it's very funny because some patients here, they tend to go to a large hospital to receive care, right? Especially for those with multiple chronic conditions. So if you say that we are going to have a system that we require all patients to receive care from family doctors, then the superintendent of large hospitals say no to the system. And why is that? Because, to be honest, easy money is also money, right? So if a patient comes to see a doctor and the doctor just prescribe exactly the same drugs for the patient, maybe 1 month or 2 months ago, and he can quickly earn the physician fee, maybe within a minute or two. So why not to have the patients to come for those mild or small diseases? Okay, so yeah, it's a problem, and actually, the government has quite a lot of different strategies to try to increase the efficiency of referral, or to encourage the hospitals to refer their student to smaller hospital or even local clinics. Yeah. But from my point of view, I would say that there's still a long way to go. Yeah.
Okay, and what about the second question about how effective is the global budget approach in controlling healthcare costs while maintaining service quality?
Okay. Yeah.
Or do
I
you have misperception about the global budget? Maybe.
uh well, the reason why I'm thinking right now, because I'm thinking that what the student asks is not actually what he or she wrote literally. Yeah, because you know what I mentioned, to provide healthcare as above certain level of quality is the consensus among the healthcare providers. And and so and also I mentioned that there's some different mechanism to monitor the quality of healthcare. So I don't believe there's a huge problem here in terms of quality of care, while uh, the doctors, they provide high service volume. But of course, if a doctor, he or she can only spend 3 minutes for a doctor consultation instead of 10 minutes, the quality is worse. Of course, yeah, I agree with that. Uh, but if you look at let me explain that in this way. Okay, so for a local clinic, in a morning or in the afternoon, usually they will have around 30 patients per term, and this similar to a local clinic in Germany. So our doctor consultation, the service volume at the local clinic level is not that higher than their counterpart in other countries. Okay? But in large hospitals, some doctors, they can have 60 patients or even 100 patients.
Yeah.
Okay, for a term. So a term is in the morning or in the afternoon. Okay, so I have a crazy case. Last year, one of my family member to see a chest doctor, and we make a reservation for the a doctor consultation in the morning, and at the exact time we saw the doctor is 4 p.m. in the afternoon. So that means the doctor used two terms to see all the patients make the reservation with him. Okay, so but there's some outlier cases, and also, oh, by the way, I forgot to mention that the NHIA actually sets some limitation for a doctor, the cap for a doctor to see the number of patients for a term. So let's say 40 or 45 patients. So if a doctor see 50 patients, so there's four more than the threshold, right? Those four more patients, the payment will have a discount. Okay, the more patient you see, the more discount will apply to you. Okay, so there's a mechanism to help. And also, I would say that it is very important because at the hospital level, the hospital, they also don't want doctor to pursue for the highest service volume. Because you can imagine that within a department, so some doctors have a very high service volume and some have very few patients. It's not fair, and the working circumstances, it's not good for all the doctors. And also, hospitals want those doctors to share with their patients, with their colleagues. Okay, to help, especially to help those young doctors to be mature. And they also want those experienced senior doctors to share with administration burden, or even the teaching load, or to do more research. So even at the hospital side, they will set some formula for physician fee. Okay, try to cap or to encourage the doctor not to pursue a very high service volume.
Okay. Okay, so we have a lot of questions here. Or maybe I just read a few more. So there is a question here about you explained earlier about the fee for services, right? And you already learned a little bit about the NHI system in Indonesia earlier from Dr. Chris Wardani. So how is the fee for service payment system, how to keep the service cost under control without encouraging the healthcare workers to overutilize the services? Because it's an often cases in Indonesia. So like you don't really need these services, but the hospital try to give you more services to increase the fee for services budget. And do you have any strategies maybe for in that relevant to Indonesian context?
Okay, so that's the reason why I spend quite a lot of time in my talk to share with you how global budget works here. So that's the most important mechanism to balance with the dark side of fee for service. So if you have more you provide more service, so the floating point value of the under the global budget will be lower, right?
Mm-hmm.
So that will create a pressure. The pressure is not come from the NHI to the healthcare provider, but the pressure is come from the peers. Okay, so but actually there's many different strategy or mechanism try to maintain the flow point value at acceptable level. For example, right now in Taiwan, since this year, they actually set hospital-specific budget for each hospital. Okay, so in the past, the global budget is set at sector level, then separate at the regional level. But now it's not only regional budget, but also they split it into small pieces for each hospitals. So you have to use your budget very efficiently. Okay, so there's less and less incentive for hospitals to pursue a very high service volume. But instead, the problem will move from overuse to underuse.
Mm-hmm.
So remember, because each hospital, they have their own fixed budget. So they tend to refer patients to other healthcare providers. Or they will set cap to set limit of, let's say, how many CT scans per month can be ordered for patients, or how many surgery per month can be had for a month, because they want to keep their cost within the budget. Otherwise, they will have some administrative punishment for the hospital. Yeah.
Yeah, I think it's related with the next question from Dinda Ajeng Fitria. She asked about the global budget that you earlier you said about each hospital have the cap, right? So it's going to be underutilized or overutilizing. But she also asked about that you said that global budget used to avoid political conflicts. But then if you have the cap and also the global budget system for the hospital, so isn't it like more just shifting the problems from the global government to the providers through the reduce of the value or the payment limitation, and also the competition maybe even between the healthcare facilities? Well, you said like you said earlier because yeah, you tend
Okay.
to just refer it to
Yes.
the hospital.
Yeah. Actually, because global budget is we say it's one type of prospective payment system. So that means the budget or the payment is preset before the healthcare service is provided. Okay, so under this mechanism, actually the payer, the national health insurance, is shifting the financial risk from themselves to healthcare providers, and this paradigm shift from retrospective payment to prospective payments. Yeah, and I would say that that's happening to many other countries in the world, and I think it's fair because you cannot ask the the payers, the NHI or any other health insurance companies to take by themselves to take the financial risk. Okay, so to shift the financial risk to the providers is a new paradigm. But the different thing is that we cannot just shift the financial risk to providers without carefully monitoring what happened to the patients. Okay, so just like what I said in the past, especially in the stage where all the payment is under fee for service, we monitor at overuse, right, or inappropriate use. So which means the patient they don't need that much of that many interventions, but actually the healthcare provider provide those excess utilization to the patients. But in the stage of prospective payment system, especially under global budget, we have to carefully monitor the underuse problem. So which means there's some unmet need of healthcare utilization. Yeah. So the way how we monitoring the performance of a healthcare system is totally different. Okay, from overuse to underuse. Yeah.
Okay. Well, I think it's answered quite a lot of the question. Oh, we have two more here. Is that okay with you? Do you still have time for?
Yeah, yeah,
Okay.
sure. It's okay. Yeah.
Okay, thank you. Then for the next question, about we already know that Taiwan is one of the country that has the best national health insurance system that you explained earlier also, but how do we explain the paradox that a system appears to be successful administratively, but still have a few problems like the increasing out-of-pocket burdens or the tendency that the patient skip the primary care and stuff? And should the success of the health system be measured by the public satisfaction, cost efficiency, equitable access, or even by providing a real impact on long-term health status? Well, it's quite a good question, but yeah, maybe it's quite hard also.
Yeah, it's a good question. It's interesting because actually I'm going to give a lecture next Monday for a course. We call it Evidence-Based Health Policies. And for my lecture next Monday, I'm talking about the comparing of healthcare systems. Compare different healthcare systems. And you are right. What the student wrote is right. Actually, based on the literature, if you look at different ranking systems, you will find different countries being ranked as top among different ranking systems. So that's because different systems, they have their different focus, or even they employ similar indicators or metrics to measure the performance, but their weightings are different. So I won't say that the Taiwan experience is the most success. No, we are not, especially if you consider the satisfaction from our healthcare professionals. Their satisfaction is quite low. Okay, compared to our tremendous high satisfaction from general population. Okay, so I would say actually the students' question also already answered the question.
Yes.
So you have to use multiple indicators to monitor the performance of a system.
Yes,
And
of course.
and what should be in the monitoring or in the metrics depends on what you think about the value you should provide to Indonesian people through healthcare. Some might think accessibility is more important, but in Taiwan, people think about the quality of care is more important. Whether they can get high-tech, very expensive care is important. So different countries, they might have different value. They might have different culture, and those will all reflect to the metrics, to the indicators they select to compare the performance. Okay, comparing performance against different countries, it is with value. It's important, but also it is important to compare your self systems across different time period and to say whether your system is improving. Okay.
Okay, thank you. Yeah, well, I think we have a lot of categories and indicators to measure the health program or health system in around the world. Yeah. Okay, one more question one more question from Saula Nisa. She asked about the mechanism of management system of Taiwan National Health Insurance for foreigners, because you said earlier that Taiwanese also said that it's not actually national health insurance because you also cover the foreigners, right? And I think you also help a lot of Indonesian there, because we know we have a lot of Indonesian workers and students that study in Taiwan.
Yeah.
Are there effective strategies to encourage these foreigners to pay their NHI premium regularly, especially for international students that, well, they might be don't have the monthly income? Because as mentioned earlier, the health insurance coverage rate is 99.99%. So do you have any explanation?
Okay. Yeah, that's a good question. Actually, this question catch me because, to be honest, I never figure out how our foreign students pay for their monthly
Insurance.
premium. But yeah, they are covered by the National Health Insurance because I said I'm also co-appointed by our Global Health Program. So all of our students are covered by NHI, but they have to be enrolled after 6 months since they come to Taiwan. So there's a 6 months waiting period. But for the local people here and for those foreign workers, actually, their monthly payments, the employer will directly save the premium from their monthly payments and to wire the premium to the NHIA directly. So to collect premium from general population here and from foreign workers here is not a problem. Yeah. Oh, but for those home health caregivers here, foreign caregivers here in Taiwan, their employer has to pay their premium to the NHIA. Yeah, that's what I heard. Yeah, but collect the financial, the premium is not a problem here in Taiwan. Yeah.
Okay, thank you very much. Well, it's quite different in Indonesia, so we have a lot of problem to collect the premium, as Dr. Chris explained.
Yeah, in the past, it also brought problem to Taiwan because in the past, because right now every citizens here we have an NHI IC card. So when you go to see a doctor, you have to show the IC card, and the doctor insert the IC card to your card reader, and also at the same time they insert their professional IC card. So use these both the IC card to identify a valid healthcare activity. So in the past time, citizens has to use a paper-based, a paper card, and the paper card is used for no more than 6 visits. So at that time, if citizens here they don't pay for their monthly premium, they are not allowed to exchange for a new reimbursement card, paper-based card. So that bring pressures for those who those who did not pay the premium to NHIA. But because we have a debate saying that this avoid their human right for health care, so we no longer have this kind of mechanism. So even you don't pay for that, you are eligible to receive care from NHI. But we still have some mechanism. For example, we will have some charity NGOs to donate for those who don't have financial resources to pay. Oh, by the way, I forget to mention one thing. For those are considered low-income population in Taiwan, they don't have to pay premium to the government. So it's defined by the law. We set a poverty line. So if your income is below the poverty line, you don't have to pay the monthly premium. Yeah.
Oh, so it's paid by the government.
Yeah. So for those people, the premium will be paid by the government. Yeah.
It's similar with us. Okay, it's the last question. I promise this is the last question.
From Anissa, yes.
Okay, so there are factors such as population growth, aging, and changing demographic structures are unavoidable in any healthcare system. So how does the Taiwan address the impact of these factors without compromising the quality of care? Furthermore, how can this approach maybe become a lesson learned from our countries? Maybe how, because we still faces the significant healthcare financing challenges. So what about the demographic?
That's a good question. Yeah.
I love the question, Professor. It's
many
very good.
many of the
Yes,
questions
yes,
should
of
be
course.
go to the
It surprised us
minister.
too.
Let me answer this. Actually, this is a good question, and to be honest, I don't have a good answer for it. The stakeholders here in Taiwan, including health policy researchers, health policy makers, medical professionals, those leaders in Taiwan, we all know that we have a very big problem brought by the aging, the super fast aging here in Taiwan. But to be honest, right now, we don't have a solution. To be honest, we don't have a solution for that. And because it's too late to have more medical students to practice in the future, right?
Yeah.
And also concerning that we have the lowest birth rate in the world. Our birth rate is either we are the top one lowest, or South Korea is the top one lowest in the world. We have a very low birth rate. So no medical students want to be pediatrics. No medical students want to be OBGYN, because you can imagine they have no future customers. Yeah, so we have a lot of problems. Yeah, to be honest. And we have some specialties, their doctor, the average age of those doctors are above 50. So yeah, we have our own problem, and that's what I said. I never think our case is the best around the world. We have our own problem, and if you look at I don't know whether you heard about the news happened in South Korea. They have a protest about increasing the number of medical students. Maybe 2 years ago, because the Korea government, they want to have 2,000 more medical students. Yeah, because what happened in South Korea is pretty much like what happened here in Taiwan, and those medical students want to be doctor in specialties for plastic surgeries because they can earn much money, right? And
Yes,
same
of course.
here, yeah. So, and also we have an projection saying that we also the number of medical doctors, the gap is about 2,005 medical doctors. So we need 2,500 more medical doctors to to satisfy our healthcare need. So actually, I don't have the answer, and I don't think that we can have foreign doctors just like what United Kingdoms or the United States do. And I would say that our case is similar to Japan because Japanese people, they don't want to see foreign doctors. They don't want to see those doctors who cannot speak native languages. And I believe that will happen here in Taiwan. Yeah, so yeah, actually, I don't have a quick answer for this question. And I agree it is important. Yeah.
Okay, thank you. Maybe we can discuss more in another topic about the demographic structure and the financing issue.
Yeah.
Okay, thank you very much, Prof. Raymond. Before we close this session, do you have any closing statement or anything that you want to told us about today's session?
Oh, thank you for having me here to have the opportunity to share what happened here in Taiwan in terms of the implementation of national health insurance. And I'm very happy to share what we learned from our case. Actually, we learned quite a lot from other countries back to the very beginning. And it's happy that it's a time that we can also help other countries to share with our experiences. And I also welcome for further discussions or even questions and future collaborations with you from your colleagues or even students. Yeah, thank you.
Okay, thank you very much again for Prof. Raymond for sharing with us today. And I think we also learned a lot about the NHI in Taiwan. Well, actually, I also sent a few journal articles to the student yesterday, so they read a little bit first about the NHI in Taiwan, so they can engage more in today's session. But then it surprised me because they have a lot of questions for today's session. Thank you very much for all of the students. But maybe I hope this session could be the first step for us to collaborate more in the future, especially because we have the similar topics about the public health and about public health management. I think Dr. Chris Wardani already interested to collaborate more with you in the future.
Yeah, exactly. Yeah.
Okay. Once again, thank you very much for joining us today, Professor Raymond. I'm sorry if we have any other problems or difficulties during our session today. I hope we can collaborate more in the future. Thank you. Good afternoon. If you have another agenda, you can continue your agenda. Thank you very much. See you again.
Yeah, thank you. Yeah, see you. See you in the future.
Thank you very much, Prof. Raymond. See you next time.
Yeah, see you.
Thank you.
Mhm.